Good morning, everyone. My name is Fehra Saeed. I'm one of the consultants in fetal medicine, obstetrics and gynecology in UK. And I'm also working as Queen Mary University as an honorary clinical senior lecturer. The topic I'm going to discuss today is the fetal physiology, the alphabets. And these are for the interpretation of CTG, that means the fetal monitoring during labor. And I'll tell you during the presentation how important it is to understand the fetal physiology while we are monitoring the baby during labor, as baby goes through a lot of stresses during this process. This is just my background. I work in East London and Barts Health covered 3 hospitals, and this is my research team. So despite of being fetal medicine consultant, we still do a lot of obstetrics, and obstetric means that we monitor babies and mothers, and we see all the mothers who are low risk in low risk birthing center in UK, while high risk babies or high risk mothers, they go to labor ward for the electronic monitoring. Now, why do we monitor babies? We monitor babies because babies go through a period of temporary ischemia that can lead to intrapartum hypoxia, and that leads to the hypoxic ischemic encephalopathy. That has got long-term neurological impairment. If you have heard cerebral palsy child, a lot of those cases may be associated with intrapartum hypoxia. As I told you, the uterine contraction causes temporary hypoxia. However, not all labors are bad, otherwise we would be extinct. We are able to cope with labor, that temporary hypoxia. The babies who have poor reserves to fight this hypoxia have problems. If you recall, that placenta has got a supply to the baby through the umbilical arteries and umbilical vein. So oxygenated blood goes towards the baby using umbilical vein, and once the baby has utilized all the oxygen and nutrients, it comes back to the mother through the placenta, through the umbilical artery. So if you measure the pH and the oxygen level in these 2 vessels, you will find that worse numbers are in umbilical arteries. Now, what we do on labor wards means in low-risk labor wards, we use this Pinard stethoscope. You must have seen it in your labor ward. It is usually used in low-risk pregnancies because low-risk pregnancies don't have risk of hypoxia. We monitor babies by listening to the fetal heart every 15 minutes in first stage of labor until they're fully dilated, and then we monitor them after every contraction in the second stage. Now, if they are high risk, then what we do, we use this machine called electronic monitor, or CTG machine, means cardiotocography machine. There are 2 transducers which are placed onto the mother's abdomen. One transducer records the fetal heart rate using ultrasound, while the other transducer monitors the contraction of the uterus. Mind you that the contraction of the uterus monitored externally on the mother's abdomen only monitors the frequency of contraction. It does not record the intensity or the severity of the contraction. Now, when we define CTG as a graphical representation, as we had a presentation just like ECG, it uses the fetal cardiac and maternal uterine activity, and we want to monitor babies to allow the early detection of any fetal distress. If CTG is abnormal, it indicates the need for more invasive investigation and potentially needing a delivery, sometimes by an emergency cesarean section. Now, if you look at this cardiotocography, there is a top part which has got the fetal heart rate scale starting from 60 to 200. The normal heart rate ranges from 110 to 160 as per NICE guideline, what we use in UK. However, it varies slightly according to the gestational age. Now we see this kind of baseline sitting at around 140. So this is the cardiac part of the CTG, while this is the TOCO part of the CTG, which is the detection of uterine contraction using the transducers. And you can see there is an amplitude mentioned. However, this amplitude does not correlate with the intensity. So the theme of my presentation today is to read the fetus, not the paper, because you need to understand the physiological responses and their consequences and try and predict the next change before it's too late. So as I said, contraction leads to temporary ischemia, and that temporary ischemia causes parasympathetic stimulation, and parasympathetic stimulation causes a drop in fetal heart rate, which are decelerations. So from the baseline, the heart rate goes down during a contraction period. As I told you that we haven't gone extinct because of certain adaptation, which we have as human, namely increased placental blood flow, for example, the cardiac output and the blood volume of the mother increases in pregnancy. Fetal hemoglobin is more higher than a normal adult hemoglobin. It measures around 18 to 22 grams per deciliter. Now, the delivery of the blood towards the baby from the placenta is twice the rate. So we have a heart rate as adult around 70 to 80, while babies have a rate around 120 to 160. So they have a double opportunity to receive the blood flow. And now there is a specific type of hemoglobin sitting in the babies called hemoglobin F, or fetal hemoglobin. It has got a high affinity for the oxygen. That means it collects a lot of oxygen. And the second beauty of this hemoglobin F is that when it sees that there is a deficiency of oxygen, it releases oxygen more easily. And therefore, fetus has got a lot of adaptation processes which saves us from problems during this temporary period of ischemia. Now, the physiology is the blood is going away from the fetus, as I mentioned, via umbilical artery. Obviously, baby has utilized oxygen and sending out more high carbon dioxide level, while umbilical vein has got a better oxygen and carbon dioxide. I have mentioned this, this picture in my presentation for a reason, because we need to understand this is the most important organs of our body, because it has an automatic SA node, which is beating automatically, and it does not have any control from any part of the body, including brain. Brain can only decrease or increase the heart rate of this area. However, it does not initiate the heart rate. Therefore, heart is the most important organ of the body. It has to carry on working until the end. This is the cylinder for the baby who is swimming in amniotic fluid, and how healthy and nice this placenta is will provide a better chance for that fetus to survive the labor. This is another very important picture to remind us that fetuses are humans as well, and therefore they have got the whole anatomy like humans. The only difference between us and the fetuses are that they can't breathe. They are depending on the supply of oxygen and nutrients via the placenta. This is a picture demonstration of the aortic arch and carotid artery. It's just a reminder that they do have hemo and baroreceptors responding to low and high blood pressure during the stress period in labor. So we use NICE. You can see I have demonstrated a lot of nice things in this picture, but NICE is actually National Institute of Clinical Excellence, and they provide us with a guideline. And whole UK in any kind of specialty will be following these guidelines. This guideline tells us about the normal baseline, which is 120 to 160. However, as I mentioned, the baseline rate depends upon the gestational age of the baby. And there is an evolution of baseline through gestation that depends upon the maturity of parasympathetic and sympathetic nervous system. Now, normal means when you have development of the fetus, the first system among the brain system develops is the sympathetic nervous system, and therefore the prematurity or the early gestational ages will have a little bit higher baseline because sympathetic is in play. Later on, after 28, 32 weeks, the parasympathetic system also starts to kick in, and therefore gradually the baseline of this fetal heart rate carries on going down, starting from 160 at 20 weeks maybe, going to around 120 to 110 at around 40 weeks. When sympathetic system is the only system present, it carries a higher heart rate. However, there is no variability. There is no variation from beat to beat. That means from one beat to the other beat, there is no variation. However, when parasympathetic system kicks in, it starts to fight with sympathetic system and saying, you have been holding the higher baseline, now let me bring it down. And they fight every moment. And that every moment fight is demonstrated on the CTG by having a variability. I'm just going to show you in one of the slides that how this fight is visible. So as I said, first sympathetic nervous system and second parasympathetic nervous system. Sympathetic increases the heart rate, parasympathetic decreases the heart rate, and they fight and causes an agreed baseline and baseline variability. So as I said about variability, you can see that this is not a straight line of heart rate. It goes from one beat to the other, and this is actually a fight between sympathetic and parasympathetic. If this fight is happening, that means your brain is actually getting some blood supply. That means your central organs or baby's central organs are well perfused. When we think that the variability is decreasing or becoming absent or increasing, that means there is a problem with the blood flow to the brain. And therefore, these are the indications to tell us that this baby does not have central organ perfused. So the brain is the second most important organs, most important organ, and therefore when it fails, that means the next organ which is in the line to fail is heart. So therefore, it's very important to look at the variability during the monitoring of the baby. The normal variability is 5 to 25, reduced variability is 3 to 5, absent variability is pencil tip, straight line, and increased variability is as dangerous as absent variability. Accelerations are the increase of the heart rate going above the baseline at least 15 beats and staying for 15 seconds to be called as acceleration. This is a sign of baby's health because this baby has got enough energy to spend on movements, and these accelerations are actually indicating baby is actively moving. Now, deceleration, as I said, due to parasympathetic stimulation, defines that the drop in the fetal heart rate for more than 15 beats from the baseline for more than 15 seconds. So these are the decelerations, different kinds of decelerations. And this is the parasympathetic stimulation. Parasympathetic stimulation is happening because we as humans, when we have stress, we are tachypnic and tachycardic. However, if we don't have a luxury to breathe, the only compensation we can do is reduction of the demand of the fetal heart energy expenditure. And that's why parasympathetic stimulation leads to decrease in fetal heart rate for that temporary ischemia during contraction. So during a normal baseline, if suddenly there is a contraction, baby drops the heart rate. And this drop is actually due to compression of the umbilical cord. And that umbilical cord tells those baroreceptors sitting on the aortic arch as well as on the carotid arteries that this is a time to save the baby, drop the heart rate. So they, through the parasympathetic stimulation, they send a message to the heart and heart rate is dropped. And whenever this contraction is over, this goes back to normal. So anything which is caused by pressure goes away after the pressure is released. However, if baby is hypoxic, means has got accumulation of carbon dioxide, reduction in oxygen level and accumulation of lactic acid due to the deficiency of oxygen and anaerobic respiration. Therefore, the chemical receptors, which are chemoreceptors at the similar place like carotid arteries and aortic arch, they feel that this baby does not have the right combination of the chemicals. Therefore, they stimulate again the parasympathetic stimulation, and that parasympathetic stimulation tells the heart to drop the heart rate. The difference here is that this is not related to the contraction and the compression of the cord. Even though the compression of the cord has been released and the contraction has gone, but still the chemicals have not gone back to normal. Therefore, these will take some time until placenta washes out all the chemicals, and therefore the return of this parasympathetic stimulation or recovery of this deceleration will take longer time. So when we see the delayed recovery of a deceleration, that tells us is not related to the contraction, is not related to pressure, it's about chemical. Therefore, this baby has a risk of having hypoxia during labor. Now, you need to understand your baby, because some babies have a small weight, they might be IUGR, they don't have fluid around them, there's no cushion, they might be infected. So we can't deal with all babies with a blanket policy. So you need to understand that which baby would need more vigilant monitoring and which baby you cannot wait any longer. As I just told you, the baroreceptor response and chemoreceptor responses, they all happen during contraction. If the contraction is related to the compression of cord, then the baroreceptors will have a very small deceleration with the very quick recovery. However, if they're related to the chemicals, means hypoxia, the deceleration will be longer and will have delayed recovery. This is a demonstration of the same thing, uteroplacental insufficiency, leading to increased carbon dioxide and angine, which will stimulate chemoreceptors, leading to parasympathetic stimulation in fall and fetal heart. And they are longer to recover to normal baseline. A little bit of definition of hypoxemia, which means decrease in the oxygen content of the arterial blood. Hypoxia is the decrease in oxygen content within the tissue. And when this tissue deficiency of oxygen affects the central organ, that's called asphyxia. You must have heard the term intrapartum asphyxia. That means tissue hypoxia leading to the organ damage. So pattern of evolution of hypoxia in a baby which have entered your labor ward completely normal will respond in a systematic way. The number one thing the baby would do if baby is under stress, they'll stop moving. They want to save the energies. Therefore, there will be a loss of accelerations. And if this baby is having some distress, you start to see deceleration. Initially, these deceleration will be normal ones. Normal ones means only with the baroreceptor pressure response, sharp drop, quick recovery, short duration, and no change in the baseline. So when the babies start to have change in baseline, that means this baby is under stress and has released catecholamine. So when you start to have catecholamines, that means this heart is actually beating more actively to supply the central organ. Heart has a responsibility to supply the central organ to keep the body alive. So it increases the baseline heart rate. However, in between, when the contraction happens, heart has to save itself. Therefore, there is a parasympathetic stimulation during that time, and heart drops its rate to keep on going. Now, the aim of this high baseline is to supply the central organ, namely brain. So as long as brain is getting the blood supply, that means brain is maintaining the variability, which I've just showed you. That's quite reassuring. The baby is still getting blood supply to the brain. The central organs are well perfused. But once the stage comes when, despite of high heart rate, the variability is not maintained, that means brain is failing, and next organ to fail is heart. So this is the time to act and get this baby out. I remember that if there is no decrease in variability and there is no increase in baseline, that means this baby might not have hypoxia, because baby has to release catecholamines and baby has to supply the brain. And if brain is getting good blood supplies, unlikely this baby will have hypoxia. Acute hypoxia, sudden drop of the heart rate, prolonged deceleration happen when you have cord prolapse, abruption, uterine rupture. Hyperstimulation means we have stimulated labor too much using medication called oxytocin or prostaglandin. Hypotension occur when we give, either we keep the woman flat on her back because of the aortocaval caval compression, or if we have given her epidural, which causes a decrease in the blood pressure. We need to understand what was happening before this sudden drop. Most of them will recover. However, if you diagnose abruption or rupture or cord prolapse, this is an acute emergency and you have to deliver these babies within 10 to 15 minutes from the diagnosis. So this is the example of acute hypoxia, sudden drop, carries on. We take decision at around 6 minutes, transfer the patient to theater, and the aim is to deliver at 15 minutes. But if it recovers, we don't have to deliver the baby. Try and remove the insult, like if she's on oxytocin or prostaglandin, we can eliminate and remove that insult to the baby. And then baby can recover and carry on rest of the labor. Long-standing hypoxia in a baby which have been having a very poor placenta. There is a placental insufficiency, therefore baby has been compensating by releasing catecholamines, using all the body organs one by one in a stepwise fashion to prioritize and save the most important organs. So if you lock the baby in a very compromised uterus, they will lose their fat. They will try and use non-essential organs first. For example, the fat will disappear, they will become skinny. And then later on, GI tract will go slow. Further on, they stop having a little bit of adequate blood flow towards the kidney. Therefore, babies will have less urine. That means oligohydramnios. The last thing happens is the brain and the heart. So heart is having a small shallow deceleration because heart is very weak at the moment. And you can see the variability is reduced. That means brain is not getting oxygen. So this baby is a long-term hypoxic baby. And therefore, this baby needs to be delivered as soon as possible. But mind you, there might be already some damage to the baby's brain. So a detailed counseling is needed before we take decisions in long-term hypoxia. We use these CTGs for the monitoring of the babies to detect hypoxia, not infection. Infection is completely, essentially a clinical discretion, and we are not doing any monitoring for the baby to detect infection. So we have to consider the whole clinical picture, and we see the maternal pyrexia, because pyrexia is just like high temperature can lead to irreversible damage to the fetus's essential enzymes. So no matter you deliver the baby later on, if baby has been exposed 6 hours to a very high temperature like 39, 40, there's a possibility there might be a irreversible damage to the fetal enzymes. So I just have a brief case review. As I told you, this is a baby who came to labor ward with the baseline of 140, and you can see this is a pressure-related, short-lasting deceleration, which we are not bothered about. They recover very well. Baby is compensating. The variability is normal. That means one block is 10, so it is actually a good variability. If you carry on, you still see babies maintaining the heart rate. That means baby has not released any catecholamines. That means baby is very happy and compensating this stress at the moment. But now we start to see slightly more deeper and longer deceleration. However, variability is still maintained. Heart rate has not gone up. That means baby has not released catecholamines, and the brain of the baby is well oxygenated. But here you start to see a little bit more higher baseline at the end of the CTG. I'm getting worried. Now you can see the baseline has gone to 160 and the variability is low. This variability is high as well. And as I mentioned, this is equally bad. I am worried about this baby now. Now this baby has got higher variability and very deep deceleration. I probably will deliver this baby. And this, what they did, they delivered the baby. You can see this, it has to be more than 7.20 to be very happy and active, but anything more than 7.1 is acceptable, and we can save ourselves in the court of law that it is not the intrapartum hypoxia. So these are reasonable cord pHs for this baby. This is a maternal pulse, so you can see that people can read this as a fetal heart rate. However, one must understand that during the contraction, the heart rate of the baby would not go up. It's the mother whose heart rate goes up. This is an IUD baby whose mother pulse was monitored, thinking baby is alive. So whenever you see acceleration with the contraction, you look at it with a very suspicious eye. And remember that the amplitude of the acceleration in adult pulse is quite bigger than the fetal accelerations. Fetal acceleration are short-lived. So we all are different people. We need to understand that, and we have to review our babies and the mothers very thoroughly. A baby of a cardiac patient and hypertensive and diabetic patient is different from a baby in a very healthy young woman. So we need to understand the environment of the baby, the growth of the baby, the current status of the baby before we put down the plan of monitoring during labor. So pay attention to the detail is the message. So father doggy asked, darling, how did this happen? And mother doggy said, I went to the pharmacist who had given me chlorpheniramine, but when I found out the tablet I was eating was clomiphene citrate. So that's why I had this multiple births. So pay attention to the detail when you're monitoring the baby using CTG. So next time when you go to your labor ward, please use this knowledge to interpret CTG using the fetal physiology. So your take-home message is that if baseline has not changed, the risk of hypoxia is low because baby has not released catecholamines. Variability is the last thing to change, therefore concentrate on baseline and deceleration. If variability is changing, that means reducing, or very high variability, that means the oxygen supply to the brain has been impaired. Listen to the fetus, not only the beat. You need to understand your fetus. You have to look at the whole labor, not just an hour when you enter that time. And when you understand the physiology, just like a normal human fetal and adult physiology, you will be able to predict the change and remain ahead of your case, ahead of your game. Thank you very much for your attention.